Hi friends, my name is Dr. Anant Nigam. I practice diabetes in Jaipur, the Pink City. I've been in diabetes practice for about 35 years now. I've really seen the paradigm shift in the therapy of type 2 diabetes. When I started practice in 1984, we just had the biconides and that also fenformin. Metformin got recognized and FDA approved much later. Then came the glimepirides, and then in 2008, incretin-based therapies really changed the way how we practice diabetes. You had drugs which were working like glucose sensors on a glucose sensing mechanism, and you did not have blood sugars going low, so your agents were working according to your current blood glucose levels, which means they were glucose dependent insulin secretion, and also suppression of glucagon was also glucose dependent. So that really changed how therapies were becoming safe, because with sulfonylureas you would get hypoglycemia at an awkward hour and was also responsible for a lot of morbidity and sometimes even deaths, because people just fell unconscious, and at that time glucose meters were not available as easily as they are today, and so those got unrecognized and people thought they had died because of something else, but probably it was a hypoglycemia. So in 2007 the injectable GLP-1s entered the market in the form of GLP-1 receptor agonists, and the first agent that came in was Byetta from Lilly. And then in 2008 the oral GLP-1 therapies, the gliptins, entered. And that really changed and transformed therapy of type 2 diabetes and also lives of millions of people, because you had oral drugs again which were working on the incretin based hormone and were getting you good control of blood glucose without the risk of hypoglycemia, without weight gain. And if you had people who were overweight, then the injectable therapies were right there. Somewhere around the same time or a little earlier, the basal insulins came in, which also changed how the better basal insulin, the insulin analogs, or what you call, and they provided safer insulin regimens with less nocturnal hypoglycemia. I think the paradigm shift now really has been, with the advancement of knowledge and research, has been more oriented to patient-centric problems. So now let me just give you 4 quick examples as we see patients today. If you have somebody who's got an atherosclerotic cardiovascular disease, then the first agent that you should be thinking of is GLP-1 receptor agonists, the proven ones. As of today, liraglutide is the one, but then there are studies now coming in with dulaglutide, which are very promising, and results would be out somewhere in the middle of this year. Now, if somebody has got heart failure or a kidney disease, then probably the SGLT2 inhibitors are the first choice. So if you've got atherosclerotic heart disease, either or, but the first choice here is GLP-1. But if you've got heart failure, the SGLT2s have really shown great promise. In chronic kidney disease also, up to moderate renal impairment, the SGLT2s are excellent agents for slowing the progression of disease. But beyond, if your eGFRs have fallen below 45, then these are not agents that you can use because they don't really give you good results. And so that's the time to look for other therapies like a DPP-4 inhibitors, which work even at lower eGFRs, get you good control without the risk of hypoglycemia, have also shown some promise as far as renal protection is concerned, with studies from saxagliptin, vildagliptin, and so on. So you've got very clear-cut patients with atherosclerosis, patients without heart disease, and these agents have shown very clear promise in patients who had atherosclerosis. So you have clear-cut agents now for these disease processes. Now you've got a patient who has hypoglycemia, frequent hypoglycemia. So you've got compelling reasons to now use agents which do not cause hypoglycemia. And again, the DPP-4 inhibitors, the SGLT2 inhibitors, the GLP-1 analogs are agents to be replaced for therapies that the patient is on to prevent hypoglycemia. Obesity is on the rise. So now you've got agents where you need your patients to lose weight. So you've got agents like the injectable GLP-1s and the oral SGLT2 inhibitors. So you've got disease agents, you've got agents which you can choose for particular conditions, and so therapies now have become more patient-centric. Of course, cost remains an issue in our country, and so for patients who cannot afford these costlier therapies, you've got to use the sulfonylureas very carefully because of the risk of hypoglycemia, and there they could be combined with one of these drugs to reduce cost, but also the major thing is hypoglycemia and weight gain need to be prevented. And so it's really the cost benefit ratio that needs to be explained to patients and just not the cost of therapy. So I think we are in a real good time where you've got real good options, you've got clear defined paradigms for disease processes which can have specific agents which address these agents. I don't say you're lucky to have got diabetes, nobody's lucky to get diabetes, but if you got diabetes in this era or in this decade or in the last 4 or 5 years, you're probably lucky that you will have newer therapies, you have newer therapies, and these agents can really help you to manage your hypoglycemia and prevent microvascular and macrovascular complications, and also the morbidity and mortality associated with type 2 diabetes. Thank you very much.